This is a very sad story. A 14-year-old girl with leukemia who received chemotherapy and also bone marrow transplantation. 8 years later, this is the echocardiogram that we recorded. I guess you immediately recognize how poor left ventricle function is. It's globally dysfunctional. You see that even radial function is very poor. The left atrium is enlarged, left ventricle is enlarged, and we also have some degree of hypertrophy because she also developed kidney failure. In addition, there's a pericardial effusion. Furthermore, the patient has secondary or functional mitral regurgitation. You see that this is an additional problem, another burden to the ventricle. I guess it's not surprising to find a strain analysis that looks like this. Severely reduced global longitudinal strain. Now, this is of course a very sad story, and it was very difficult to actually bring the patient out of heart failure, but eventually she actually died. So I believe it's very important that we of course detect this problem in an earlier stage. With conventional methods, with looking at ejection fraction, we're often simply too late. What do we know about chemotherapy in the heart? Well, we know that chemotherapies have cardiotoxic effects. We know that it is the leading cause of death in cancer survivors, and that there is a number of patients that have left ventricular dysfunction and are still asymptomatic. So they might develop overt heart failure in the future and become symptomatic. There are many chemotherapies that can affect the heart. No matter if you're looking at anthracyclines or alkylating agents or TKI monoclonal antibodies. And the rate with which chemotherapy-induced cardiomyopathy occurs is quite frequent. In some studies, you will find rates of even 26%, as with doxorubicin here. And in another study, it was shown that you have an incidence of heart failure occurring in 15% of patients who take the combination of anthracycline plus trastuzumab for 5 years. So it's a major problem that we're confronted with. But let's hear which experience Milan has and what his take is in the role of speckle tracking in chemotherapy patients.
I remember a case of the patient that came to our observation before the chemotherapy, and at the time the recommendation did not introduce the speckle tracking in the evaluation of the left ventricular function. That patient had left ventricular hypertrophy and a reduction of speckle tracking. The oncologist decided to treat the patient even if we advised him that the patient had a reduction of global longitudinal strain. He developed suddenly symptoms of heart failure and could not do the chemotherapy anymore.
This already shows that a reduction in longitudinal strain is an early sign in the process of developing cardiomyopathy if you take chemotherapies. Well, in the meantime, of course, strain has been integrated into the guidelines, and we very well know about the role of speckle tracking and how important it is. What do the guidelines tell us? Well, up front we have to understand that, of course, many patients who receive chemotherapy are older, and they already might have some reduction in strain because they have cardiac pathologies, hypertrophy, coronary artery disease. So we cannot take the absolute value and say this is the cutoff value where you should get chemotherapy or not. We have to compare the baseline with the post-chemotherapy strain. And from the studies that have been formed, we now define a cutoff value of 15% reduction between the baseline to post-chemotherapy as a sign that chemotherapy has a negative effect on the function of the heart. Of course, if you have a value somewhere in between, it's a little bit more ambiguous. But 15 is now a hard cutoff value which, with a high sensitivity, detects chemotherapy-associated cardiomyopathy. The following diagram will show you how we can integrate this information in our patients who receive chemotherapy. Well, first of all, we still look at ejection fraction. If we have a drop in the ejection fraction of 10% below a value of 53%, then this is already an indication that the patient has chemotherapy-induced cardiotoxicity. So yes, there we have the problem of cardiotoxicity. If the patient does not have this reduction, then we have to look at global longitudinal strain. Is there a drop of below 8%? Then there is no evidence of clinical or subclinical dysfunction. If there is a drop of more than 15%, yes, then there is subclinical dysfunction and cardiotoxicity. Somewhere between 8 and 15 is a little bit ambiguous. I guess these are the patients that you would follow up more closely to see how they develop with further chemotherapy. Don't forget, however, that we also have troponin, which we can use because we now also know that patients who have cardiotoxicity develop elevations in troponin. There is overwhelming evidence in the literature that strain is an early marker of cardiotoxicity in so many drugs. And what we also now seem to appreciate is that it is especially this inner layer, the layer where the longitudinal fibers are oriented, which seem to be most vulnerable to cardiotoxicity. Maybe in the future it would be better to only look at the inner layers, but this is open for discussion and for further research. Let me exemplify the true value of longitudinal strain in the setting of oncology patients. This is a patient who already received a certain amount of cycles of anthracycline and he's about to get more. And here is the echocardiogram that we performed. Now, if we look at the ejection fraction, it's way above, of course, 55%. And if we eyeball ventricular function, it also looks quite normal. But this is the strain. Now, this is a strain value which is still, I would say, in the normal range. It's maybe in the lower normal range where you do see some regions which have less strain than maybe other regions. And under normal circumstances, you would just give the patient chemotherapy. But this is the study that we performed before chemotherapy. We had a strain of minus 22.8. So this is definitely a drop of more than 15% from the baseline. So this already indicates that there is some left ventricular dysfunction which is occurring. Again, should we discontinue chemotherapy in this patient? Well, it obviously depends on the necessity of chemotherapy, and I would probably not definitely say that he should not get it, but it's something to think about, and these are these patients where you probably have to be very, very cautious with chemotherapy and maybe even consider reducing the dose or changing the regimen to some degree. It's definitely a difficult decision to manage these patients, but let's ask Professor Steve Lester from the Mayo Clinic what he does in such a clinical situation.
So when we see patients in our practice that have a normal ejection fraction, but say a reduction in strain, or even an elevation in troponin, another biomarker, we would not stop the chemotherapy because of course that has implications for their long-term management of their cancer. But what we would do, and this is somewhat empiric, is to begin cardioprotective therapies. And in our practice, that generally begins with beta blocker therapy. Some use ACE inhibitor or angiotensin receptor therapy up front, or even a combination of both. But again, without definitive clinical evidence, what I can say in our practice is that we tend to begin with beta blocker therapy as a cardioprotective agent.
As Steve mentioned, I think we're only at the beginning of understanding which therapeutic implications a reduction in longitudinal strain actually has. Of course, the studies are not out there yet, but I'm sure they will come. But this does not prevent and should not prevent us from using longitudinal strain already now, before the data is out there, because there is so much evidence in other areas of heart disease that longitudinal function is an important parameter.